Hello, my name is Martine Sanin, and I will be starting this discussion on geriatric emergencies with my colleague and mentor, Dr. Yula Wang. In this first slide, I will review the objectives of this talk, which is first to review the challenges of caring for older patients in the emergency department setting. We will review some common complaints and atypical presentations which require emergent management and introduce geriatric assessments and interventions which may alter and improve patient outcomes for older adults in the acute care setting. The emergency department, in many ways, is viewed as not well suited for the needs of our older adults. There has been an increasing trend to change the way in which care is provided for our older adults. And while the ED can often be seen as a very chaotic and dangerous place, it is an important setting of care where our older adults who present not only for acute injury and trauma, but oftentimes the exacerbation of their chronic conditions, at times sent in by their primary care providers to expedite complex evaluations or workup, or that they're plagued by geriatric syndromes and no longer safe in the community. In the last several years, we've seen a growth of interventions to improve this model of care to meet the needs of our older adults. This slide highlights the commonly encountered emergency presentations for older adults. This original work published in the Annals of Emergency Medicine highlights that falls still remains one of the most common presentations for admission to the emergency department, and it is also a very common geriatric syndrome. A fall may also be the presentation of any of the other listed comorbid conditions we see: an acute cardiac event, complications with polypharmacy and adverse drugs, alcohol and substance abuse, abdominal pain, and infections. More recent studies have also looked at specific patient populations and outcomes. I'm highlighting that individuals or patients living with dementia or advanced disease, such as cancer, tend to have more difficult and complicated outcomes after an emergency department visit. And when we think about the characteristics of our older adults who present to the emergency department, the literature supports a number of common themes that older adults tend to be more challenging because they present atypically. By this, we mean either a delayed presentation in illness, a vague presentation of illness, or even an altered presentation where the only symptoms are a generalized weakness or a new fall or new confusion. That older adults tend to have more cognitive disorders. They're living with a number of chronic comorbidities that make their workup a little bit more complicated. And you add to that this idea of polypharmacy, the number of medications to treat a number of their comorbidities, increased frailty. They tend to have a greater severity of illness, requiring a lot more diagnostics and tests, which lead to delayed diagnoses, and unfortunately associated with adverse outcomes. Furthermore, for many of our older adults, that visit to the emergency department is often considered a sentinel event, and that older adults are at greater risk, as I mentioned before, of increased medical complications, functional decline. They're more likely to be admitted and require admission to higher settings of care like an ICU. And prolonged ED waits and overnight stay, waiting for that ward admission, is also associated with greater morbidity and mortality. And not too surprising, for patients who are even discharged from the emergency department, nearly a third experience a revisit within 30 days to the hospital or a poor outcome such as mortality. Now that we've reviewed some of the background in terms of care or emergency care for our older adults, we're going to hone in on some of these teaching points through several case discussions. The first case is the nursing home transfer. Hospitalization happens to be very common amongst this population, with nearly 25% of patients admitted to skilled nursing facilities who often are seen to get readmitted to the hospital within 30 days. And while we know not all hospitalizations are avoidable, and in these post-acute care facilities, there is medical oversight, there are often times when a patient does have to return to the ED. When a patient arrives to the ED from a post-acute skilled nursing facility, it's important to look what is on that nursing home referral. There's a lot of information shared by the providers that can help guide their clinical care and outcomes. So, reviewing what was the detailed reason for the referral for the emergency care evaluation? Was there a contact person, a nursing home provider, a physician, a PA, or nurse practitioner? Details about the patient's allergies, medication lists, and current medications, as in many of these facilities are able to check labs and start treatments in the post-acute care facility. An indication of what their advanced directives look like. Is there a DNR order or a medical order for life-sustaining treatment to guide what care would look like moving forward? And furthermore, information about prior hospitalizations, major surgeries, and probably most important, what is the patient's baseline cognitive and functional status? So here we have a case of a 77-year-old man who's transferred from a nursing home with increased confusion after a fall, which occurred 2 days prior. At baseline, we know that the patient is 8 alert and oriented times 2 to 3. He's wheelchair dependent. However, he's been an active participant in his rehab and in group activities. The fall, unfortunately, was not witnessed, but it is documented that there was no loss of consciousness or head trauma. On exam in the emergency room, we get a set of vitals, which is indicative of a blood pressure of 80/50. He's tachycardic to 110 and febrile to 102 degrees Fahrenheit. His finger stick is 160. Oxygen sat is 94%, requiring 2 liters of oxygen. Our patient looks ill. He's fidgeting and pulling at his sheets. He has dry mucous membranes, no teeth. Um, his neck is stiff in all directions. On his chest and cardiac exam, we notice there's bilateral rales, and he has a 2 out of 6 holosystolic murmur. His abdomen is soft and non-tender. A fecal cult test is done, and he's guaiac negative. In terms of his musculoskeletal exam, as he's lying in the bed, you notice that his leg and the left lower extremity is shortened and externally rotated. He's groaning to pain. He's moving 3 out of the 4 extremities. He's somnolent, inattentive, and difficult to arouse. On presentation to the ED, we are able to get immediate workup done with blood work consistent of a white blood cell count and a CBC of 25,000 with a left shift, a basic chemistry indicative of a creatinine of 1.8 and a lactate of 5. His coag studies are normal, and a urine study is done, comes back positive with estrius and nitrates and numerous WBCs. He gets immediate imaging as well, a chest x-ray, which is unremarkable with no infiltrates. He has a head CT, which shows atrophy, but there's no blood, no shift or mass. And rapid bedside ultrasound to rule out any other emergent conditions are done in the ED. And we are waiting further imaging with a CAT scan. So in our patient presenting with a fall, we need to identify immediately some of the primary problems. The first is the fever. He's hypotensive and altered. This should give pause to consider septic shock as a major condition to address. In our nursing home patient, you have to think broadly about the sources. It could be pneumonia, urosepsis, or soft tissue infection, but also thinking outside of the box of a severe CNS infection or endocarditis. Next, his physical exam is concerning for a left hip fracture. Should we be worried about anything else, like a fat embolus, as the fall had happened a couple of days ago? A a possible CNS bleed or associated neck trauma based also on his physical exam, and finally, delirium. This acute change in mental status, is it due to an infection? Is it due to pain? Is it due to infarction? Oftentimes, we're competing and thinking about all of these issues contributing to his presentation. This is likely a uroseptic nursing home patient, and our goal is to view the whole patient and consider other sources of sepsis, including C. diff, an intra-abdominal abscess, necrotizing fasciitis, and endocarditis or osteomyelitis. As a patient is coming from a post-acute care facility, you want to also assess the risk factors for multi-drug resistant organisms, especially for a patient who's had recurrent hospitalizations or has any indwelling catheters. We need to pan culture the patient and start broad in terms of antibiotics. A patient like this would be started on something like cefepime and vancomycin and add flagyl if necessary. If you think C. diff is in the picture, you want to be aggressive with early goal-directed therapy, including IV fluids, and really consult your infectious disease providers as necessary, as our older patients tend to be at risk for more complicated infections. Again, a little bit more on early goal-directed therapy, in which you want to be aggressive, especially with our older patients who have good premorbid function. Remember your ABCs and resuscitation, immediately starting broad-spectrum antibiotics. Review from the nursing home paperwork, their advanced care planning. Is there a DNR or DNI? The indication for pressors for a patient, especially if there's no response after fluid resuscitation. Be mindful of sedation and analgesia. You certainly want to address the pain in a patient with an acute hip fracture, and what further imaging you can expedite while in the emergency department. A non-contrast head CT, a CT cervical spine. You want to rule out bleeds or delayed bleeds, such as a subdural or intracranial hemorrhage. Certainly, hip and pelvic x-rays to confirm the suspicion of a fracture, and you may need to proceed with CT imaging for in imaging that is unclear. And finally, calling the nursing home to get additional collateral and information from their caregivers. So a few take-home points in terms of geriatric falls and fever and altered mental status. The fall may be an innocent trip or fall, but it often represents a sentinel event. The older patients are, the greater the risk for these falls to be traumatic and it be associated with a fracture. Prioritize your skeletal survey, your scene survey, checking for the airway, breathing disability. Check that EKG to make sure there's no cardiac event that led to this fall. In pursuit of an infection, you always want to also get a rectal temperature. A fever may suggest more of a bacterial rather than a viral source. However, be mindful that the absence of fever does not exclude that a patient may be infected. The older the patient, the more likely they are to fracture. And also be mindful of antibiotic usage, as antibiotic resistance is more likely in our nursing home patients. You also want to address the pain and remember the mantra in geriatrics: start low and go slow. So opioids such as morphine, if his blood pressure can tolerate and if the renal function is improved, but alternatives such as fentanyl or hydromorphone may also be considered, especially if the patient has been on chronic opioids or has longstanding chronic kidney disease. For a patient with a hip fracture, consider a femoral nerve block. In terms of care, he may need a central line, especially if he needs fluids and pressors. And for this patient, you may want to consider consulting our ICU. And while he does need surgery, ortho cannot operate until the patient is more clinically stable. In this case, we also review a fall presenting as geriatric trauma. We know falls are very common in older adults. Nearly 1/3 of community dwellers fall every year. 60% of patients from skilled nursing facilities will also present with a fall. And for many older adults, those who have had a fall, nearly two-thirds will fall again within 6 months. A fall or traumatic fall is considered the number one cause of death due to injury. And for, in particular, the oldest of old, nearly 25% die within 6 months after a hip fracture. Trauma activation is extremely important in older adults, and they are often under triage. So that's why it's important to recall or remember that a fall can be our geriatric trauma. Older adults tend to have 4 times greater mortality associated with a fall, more likely to have an occult fracture, in particular, dangerous fractures. So, cervical spine injury at the level of C1 to C2 can be a devastating and fatal injury. Head injury is also more common with our older adults. While there's more space due to brain atrophy, they may have an asymptomatic intracranial hemorrhage. 1 out of 6 of these patients are asymptomatic. You have to be mindful of medications, in particular, things like warfarin and new anticoagulants, which can often lead to delayed bleeding, um, even with minor trauma. In this case, we also touch upon fever and sepsis in older adults. And it's important to remember that temperature may be less sensitive amongst our most frail older adults. Older adults may not have the same localizing symptoms or focal findings on exam, and those with cognitive impairment may not be able to communicate their symptoms. The IDSA, the Infectious Disease Society of America, recommends modifying the definition of fevers for older adults. And by this, it means considering a single temperature above 100 degrees Fahrenheit, or 2 oral repeated temperatures above 99, or finally an increase in temperature 2 degrees Fahrenheit over the baseline temperature for that individual. You also have to have a lower threshold or index of suspicion when considering the diagnosis of sepsis in our patient population. Two-thirds of sepsis admissions are, are seen in geriatric patients. And risk assessment tools such as the SIRS criteria or the QSOFA score um, are less sensitive to pick up sepsis in our older adults. So you have to be mindful of things like altered mental status or failure to thrive as the only presentation. Moving on to our next case of a change in mental status. Here I share the case of Mr. W., a 75-year-old man brought to the emergency department by his 2 daughters. He'd been agitated and paranoid for the past several months. He seems nervous and preoccupied with cleaning his house and attending church. For the past week, he's been walking more and talking constantly, and today was found incoherent. He had baseline some mild cognitive impairment, but was in good health and takes no medications and no alcohol use. On exam, he is thin, he's agitated. He has a blood pressure of 150 over 100 and tachycardic to 120. He appears disheveled. To the right, we see his head and neck exam with this obvious stare. His neck is supple, chest is clear. Cardiac, again, is that he's tachycardic, but no appreciable murmur. His abdominal exam is benign. Musculoskeletal, there's no edema. In terms of a neuro exam, he's a normal mental status, but his reflexes are symmetric and hyperactive. As you consider what are the likely causes of this new change in mental status or this acute psychosis, it's important to differentiate organic or medical causes versus functional causes. Psychosis should be considered to be organic or non-psychiatric until proven otherwise. Listed here are a few diagnoses to consider, such as drug withdrawal, serotonin syndrome, or other drug adverse reactions, or hyperthyroidism. New onset psychosis is relatively rare in older patients, so diagnoses such as paranoid schizophrenia, dementia with psychotic features, or paranoid personality disorders are diagnoses of exclusion, as late onset psychosis is exceedingly rare in our older adults. As part of his emergency room evaluation, he has a chest x-ray, and on the left, you can see a normal chest x-ray. However, on the right chest x-ray, you notice a substernal goiter. It is often found incidentally on x-ray or CT scan and may cause obstructive symptoms such as dyspnea, wheezing, or cough. It's important to recognize that thyroid storm is a clinical diagnosis. Often a patient will have the physical signs as described, a goiter, wide pulse pressure, and other features include fever, tachycardia, diaphoresis, and emotional lability. And it is important for the ED clinician to really recognize thyroid storm in this differential. So the first step would include checking some additional labs, sending a thyroid study and a T3, T4 in the diagnosis of hyperthyroidism or hyperthyrotoxicosis, a hypermetabolic state. The TSH is low, but the free T4 is high. T4 can be elevated in psychiatric disorders, but TSH would be normal. Other diagnoses are unlikely based on clinical course. An alteration of his mental status may be the only sign of um, this disease. So certainly with this new acute change in mental status, you may ask the psychiatrist to see the patient, but it is imperative that this patient has a thorough medicine evaluation and perhaps even ICU evaluation. You want to lean on your specialist, such as endocrine, for assistance. Acute treatment generally consists of methimazole or PTU to decrease synthesis, iodine to prevent the release of hormone once the synthesis is blocked, a beta blocker to prevent peripheral effects, and steroids if necessary, and there's evidence of adrenal insufficiency. Long-term ablation would consist of radioactive iodine, and surgery is also an option for patients who are younger. So a few teaching pearls regarding this acute change in mental status. I highlight here this idea of delirium, this acute change that often requires a more thorough medical evaluation. Abnormal vital signs and altered mental status favors medical over functional causes, and delirium often has reversible medical causes and more common with our patients with dementia. Hyperthyroidism is presented in this case is a clinical diagnosis, not necessarily a lab diagnosis. An older adult with hyperthyroid may not have the adrenergic hyperactivity and may actually have more of a blunted response. The differential for organic causes of agitation is extremely broad. You have to consider drug withdrawal, adverse drug reactions, substance abuse, inadequate pain control, hypoxia, and for our older adults, even something like urinary retention or constipation. And why we think about delirium very often, this is our medical emergency. And we know our older adults have a number of predisposing risk factors, in addition to their advanced age, cognitive impairment, baseline ADL impairment, and their higher medical comorbidity, dehydration, and for the sheer nature that they're in the emergency room with severe illness. But a number of things can also precipitate a delirium, which you have to pay attention to. And your differential is broad. It's really important to think about all potential insults that can lead to a delirium, including an acute CNS event, any organ dysfunction, nutritional deficits, an infection, fluid and electrolyte abnormalities. As I mentioned, urinary retention or fecal impaction, endocrine disorders, drug withdrawal, and baseline sensory deprivation, which we tend to see greater with our older adults. And finally, when you consider that delirium in itself can be a medical emergency and the only presentation is this acute change, the confusion assessment method is the gold standard screening tool. Unless you're using a validated tool, delirium can often be missed. The CAM, as listed here as a reminder, includes the first two features, that this is an acute change and that there's some level of inattention, followed by one of the other features, disorganized thinking or altered level of consciousness. Once a patient screens in for delirium, it is important to go back to that broad differential and rule out any reversible etiologies. Finally, case 3, a case of polypharmacy and potential adverse drug events. Here, I introduce the case of RL, an 85-year-old female with Parkinson's, who also presented to the emergency room with the two common presentations of fall and altered mental status. She has a history of Parkinson's that was diagnosed in 2017, and below is listed her medications. She's on Cinemet twice a day, in addition to controlled release 1 tab at night. She presents after she's had 3 falls in the past month and reports feeling lightheaded, faint, and her family more confused. While in the ED, she has a trauma evaluation and she has the appropriate imaging, including a head CT and cervical spine, which were negative for any acute bleeding or fractures. X-rays of the hip and pelvis and ribs have ruled out any hip fracture or any acute fractures in her body. She also has an expedited cardiac and infectious workup, including cardiac enzymes, a transthoracic echo, and a basic infectious workup with negative urine studies, negative respiratory panel, and negative for COVID. You're the geriatric consultant, and the ED is asking, is the patient ready and safe for discharge, as her ED evaluation has been negative? So we take a closer look at her case through the geriatric lens and using the 5M framework, which has been introduced. We learn that while she's been lightheaded and dizzy and has had multiple falls, while her imaging and labs were reassuring, at bedside she was found to be severely orthostatic. We take a look at her medication list and stop her 2 antihypertensives and call her pharmacy and note that she's been recently started on Florinef. The patient is confused, didn't remember that this new medication was added, and didn't know she was supposed to use it. We also confirmed at the pharmacy that she was started on a new medication called entacapone. This was started by her neurologist. We get additional collateral from her son and her aides who report that over the past few weeks, the patient has also had increasing hallucinations and delusions since starting entacapone. The son also shares that he worries that her confusion is getting worse in the ED and her goals are ultimately to return home. As part of the comprehensive geriatric assessment that's done quickly in the emergency room and getting this additional collateral, the patient is instructed to taper off this new medication, and she's actually discharged with quetiapine for agitation as needed. This patient was able to be discharged from the emergency room with a plan for close follow-up with her primary care provider, her neurologist, and after optimization of her medication list. In this case, it's important to understand the progression of a common chronic illness known as Parkinson's. Parkinson's tends to affect nearly 1 to 2% of patients over the age of 65, and it is the 14th leading cause of death in the US. However, what's interesting is to recognize some of the non-motor symptoms, which are often under-recognized or untreated and have significant impact on a patient's quality of life. This includes some of the neurobehavioral changes, such as anxiety, sleep disturbances, and hallucinations, this autonomic failure and orthostasis that were described in our case, with additional sensory impairments and malnutrition. It's also important to recognize that nearly 75% of patients with the Parkinson's with disease develop dementia in the later stages of their diagnosis, and nearly 50% will die within a hospital or healthcare facility. The hallucinations and agitation that we were described here are actually part of the Parkinson's disease and a phenomenon known as Parkinson's disease psychosis. This is probably one of the most concerning and multifaceted symptoms, non-motor symptoms associated with this diagnosis, where a patient can progress from really minor illusions to hallucinations with insight to severe delusions. Some of these hallucinations are certainly considered part of the disease and expect them to develop, even as part of their medications, because of the dopamine agonist effect. And certainly, one way to address it, if pharmacological interventions are needed, is to work closely with the patient and their neurologist with options to either down titrate their levodopa, consider the initiation of an acetylcholinesterase inhibitor, such as donepezil or rivastigmine, and if indeed the goal is to treat the symptoms of hallucinations or severe insomnia, the use of an atypical antipsychotic like quetiapine is preferred rather than haloperidol, which can actually worsen the Parkinson symptoms. In this case, we highlight how we brought in the field of geriatrics into the geriatric 4M framework, similar to the geriatric 5M framework, now being utilized in various clinical settings. The geriatric 4M screening tool now has been widely introduced in the age-friendly health system and is also applicable in the ED setting, where we're taking into consideration the patient's baseline cognition, mobility, medications, and what matters most into their care. In this case, the 4M model helped us recognize several things in terms of her mind, understanding how the hallucinations in her advanced Parkinson's were leading to psychosis, her mobility, how the reasoning behind her falls, and this orthostatic hypotension and interventions that could be done. And finally, a careful review of her medications and opportunities, even in the emergency setting, to review medications, de-prescribe medications, and identify high-risk medications. Polypharmacy is common also in our older adults in the ED and has been associated with increased risk of morbidity and mortality. And thinking of the emergency room as an opportunity to really pick up on these things for our older patient can really impact care. So I end here with some highlights in the approach to older adults with emergencies. A few take-home points I hope you remember is to really consider atypical presentation of illness is often the typical presentation in our older adults. Be vigilant about delirium. This is our medical emergency, and remember to use a validated screening tool such as the CAM, Confusion Assessment Method, to really identify delirium that can often be missed. We need to accept that our older patients may require more time and a bigger workup, and will often need close follow-up if they're discharged. Review medication list, any recent changes in medications, and in particular medications that have high risk for our older adults or may be seen as potentially inappropriate. A visit to the ED is also an opportunity to assess and document goals of care in advance. Remember to practice preventative medicine in addition to screening for common geriatric syndromes and reviewing for medications. And really thinking about the geriatric 4M framework to really assess the care needs of our older adults as they present in the acute care setting. Thank you.
Okay, thank you, everyone. So I'll continue with the second portion of this talk, and it will focus more specifically on the concept of the geriatric emergency department. And you'll hear some of the reiteration of the themes and emphasis of the 4 or 5 M's that you heard earlier by Dr. Sannon. My name is Yul Huang. I am an emergency physician. I'm a professor of emergency medicine and population health at NYU's Grossman School of Medicine. Just as mentioned before, just for disclosures, you're going to hear me talk a little bit about and reference programs that we have funded by foundations and also by the NIH. And these specifically will be talking about the Geriatric Emergency Department Collaborative. And I'm also part of a research network really focused on geriatric emergency care. So I think what you heard earlier is we are increasingly seeing more older adults come in the emergency department, and as such, they are receiving emergency care. But we also know very well that emergency departments are no place for the elderly. It's a very challenging, chaotic environment. And although this editorial was written more than a decade ago, I would say a decade later, we're not necessarily seeing that things have improved that much and continue to be challenging, especially as our population ages. But I think there is an opportunity specifically with geriatric emergency departments to address the needs and care for older patients. And so, for this reason, a little over almost a decade and a half ago, we wrote this concept paper called the Geriatric Emergency Department. Sean Morrison and I really proposed at the time that this should be a paradigm shift away from just the usual approach that we have for emergency care with older adults and move towards design and, more importantly, care that addresses the special care needs of older adults. If we have pediatric EDs that exist for younger patients or psychiatric EDs for those that have mental health needs, what about our older and aging population? And with this, we proposed JEDIs or geriatric ED interventions. This incorporates structural elements, so really making it more senior-friendly environment with regards to lighting, precautions for falls risk with flooring, noise suppression, providing hearing assist devices to allow also hearing supports. But more importantly is really also around the processes of care. So really screening and addressing geriatric syndromes, making sure that we don't miss and that we recognize when someone may have delirium, recognizing patients that might be at greater risk for poor outcomes with specific screening assessments, and facilitating care transitions with persons like nursing discharge coordinators. I want to highlight when we wrote this piece back in actually before 2007, there were no so-called geriatric EDs or senior EDs. And when it was published in the Journal of the American Geriatric Society. We had a hard time actually getting this accepted in our own emergency medicine journals. Well, a few years later, we started to really move forward in advancing this concept. And several of us, as part of task force groups and interest groups, in partnership with 4 specialty organizations, so 2 emergency medicine organizations, ACEP, the American College of Emergency Physicians, SAEM, Society for Academic Emergency Medicine, along with AGS, the American Geriatric Society, and the Emergency Nurse Association, endorsed and proposed the geriatric ED guidelines. These guidelines, since 2014, have now been endorsed by additional organizations and propose sort of recommendations at minimum of what emergency departments should be doing when it comes to care for older adults. So incorporating many of those concepts that you heard earlier. So structures, processes, training and education, and also what happens with patients after they leave the emergency department, especially for those returning back to the community. So ensuring that they have supports to safely get back home. These guidelines also echo a lot of the themes that you heard earlier with the 4 M's. So the 4 M's is a concept around age-friendly healthcare that now is really endorsed and moved forward by the IHI around mobility, mentation, medication, what matters. And as you heard earlier, maybe even this 5th concept of elder mistreatment. So instead of just calling it the 4 M's, I would say, the 5 M's. And as you saw earlier with the presentation, sort of the representation on the hand of what those 5 M's are. So how do we incorporate these 5 M's into the emergency department? Well, we could start with mobility. So as you heard in with the earlier example, and as we know, falls are a geriatric syndrome. But it's not just about falls. When patients come into the emergency department, we have to make sure that we assess that they don't have a fracture, they don't have a dislocation, that there's not an acute medical emergency going on. But it's also important for us now to think about the concept of mobility. And it's not just an event, but how do we prevent them from having this happen again? So in addition to making sure they don't have this acute medical problem, we have to also try to conceptually, from the ED perspective, think about how do we prevent it. So really carefully reviewing medication with medication reconciliation. Maybe that was part of the etiology for why they got dizzy and fell. Getting a good history from the community paramedicine, so the EMTs or the paramedics that pick up the patient and can comment to us about the patient's home situation and safety. Were they a hoarder and there are a lot of tripping and falls risk hazards around the home? And assuming we get all of that information cleared, if we're ready to discharge the patient, can we even assess them if they're a falls risk and have mobility issues to get PT to now see the patient while they're in the emergency department and enable and get them situated such that we can help them with improving their gait stability. A quick assessment, there are many types of mobility and falls risk assessments, but one that can be incorporated easily in the emergency department is the timed up and go or the get up and go test. The next concept around mentation actually covers both delirium and dementia. Delirium, as we know, is in many ways another vital sign when it comes to older adults because it can change. They may come in and at this moment in time they may not have delirium, but if you leave them in the emergency department or don't give them their medications or address something, they may subsequently develop delirium. And it's change from their baseline mental status, change from their baseline with regards to inattention, disorganized thinking. I think for many in the emergency department, they typically think of delirium as an agitated patient, but that's actually probably the less common. The more common form of delirium that we see in the emergency department is hypoactive delirium. And so picture the sleeping older adult or the patient that the family members send in because they've been more lethargic over the last couple of weeks, the last couple of days they haven't been eating. This could be delirium. And so screening tools that have been specifically developed for the emergency department include the brief cam or the 4AT, which is more commonly used in Europe. Some may say dementia is not an emergency, but I would say the reason why dementia in itself should be considered as part of emergency care is because those that have a history of dementia are at greater risk for developing delirium. So there's that opportunity now to bring in prevention and really assure that we don't have individuals or patients with dementia in the emergency department be put at greater risk for developing delirium. Family and caregivers are our best friends in the emergency department because they can not only give us a history about the patient, but they can also be at the patient's bedside when your emergency department allows it and advocate for this. In calming the patient, reassuring the patient so that they don't get disoriented, and really notifying the clinicians in the ED that something might be going on. Care transitions here are really key. If we miss that someone may be at risk for undiagnosed dementia and we send them home with complex instructions, there's a high chance they're not going to be able to follow through with that those care transitions. And if we suspect someone of having potentially undiagnosed cognitive impairment or dementia, then there's the opportunity, and there's a big opportunity, especially in the emergency department, to refer these patients for further evaluation and assessment. So while we may not be diagnosing someone with dementia in the emergency department, we can most certainly pick it up and ensure that they get referral. A quick screening tool there that could be used in the emergency department is the 6-item screener. Medications, you heard a lot earlier about how medications are a big part of screens and assessments in older adults. I think in this case, medication reconciliation is key, and it's not just for those that are admitted, but if we can do this now also for patients that are being discharged, that's critical, and ensuring that we understand what patients are taking, what they have available, and if there's potential risk of they're not taking their medications or having the ability to access their medications. De-prescribing is another area that's very big in geriatrics. It's a little bit harder to do from the emergency department setting, but if there is that opportunity, that's a big opportunity. Specifically promoting with your emergency departments the understanding of what Beers criteria are. I think if you were to go to many emergency clinicians and tell them these are Beers medications, they wouldn't know what Beers medications are. And this is a list of potentially inappropriate medication in older adults. For those that are from nursing homes, this was initially developed but has now expanded and spread to application in inpatient and outpatient settings, and working with embedded pharmacists. Many emergency departments actually have pharmacists that are in your emergency department reviewing patient medication lists and working with them now to screen for and ensure that from the emergency department we're not prescribing Beers medications. There's actually an effort by AGS to develop specialty specific Beers medications, because in some cases, some of these medications on the Beers list, they're not avoidable. Benadryl or diphenhydramine, as an example, is often given for allergic reactions, and it's not inappropriate if that's what it's being used for. What matters? I think in this day and age, especially in the United States, where we're so much about service, we've got like Apple service and the ability. Why can't we deliver that type of service when we're talking to our patients in the emergency department? What matters includes goals of care, goals of the emergency department care. Why did the patient come to the ED? Most don't come in and with the plan that they want to be admitted. So for us to really sit down and understand with them why they're in the emergency department, what their priorities are, and how we can facilitate that. So it could be that this is an individual who's just having increasing, worsening shortness of breath, that they're not able to exert themselves and help take care of their spouse, but they really just want to have the shortness of breath relieved and improved such that they can get back home and care for their spouse. So hearing and understanding that will make a big difference in terms of some of the disposition and care planning that we might have with patients in the emergency department. There's always the opportunity to bring in early introduction and discussion around advanced directives. And so this too is another opportunity, especially for those that don't have those documented. Finally, I'll say the fifth M when it comes to elder mistreatment. This is something that's missed all the time. 1 out of 10 older adults experience some form of elder mistreatment or elder abuse, whether it be physical, mental, verbal, financial, sexual. These are things that older patients are at risk for. And picture the scared older adult, the patient that maybe doesn't really want to, is not comfortable giving a history, especially if there's another care partner or someone accompanying the emergency department. It's important to separate the patient from these other individuals to get a better sense of the history. And there are increasingly now screening tools specifically being developed for the ED setting to pick up on older adults that might be at risk for mistreatment. So most of these concepts can be found in the GERD guidelines. As mentioned before, the first pass of the GERD guidelines were endorsed and developed by 4 specialty organizations. You can find the guidelines available on all of their websites. An updated version of the GERD guidelines are now currently being developed and in review. A much more rigorous systematic review is in process. For more information on how to implement many of these programs, I'd mentioned to you before about the Geriatric ED Collaborative, or the GEDC. If you just go to the website, there's many resources available on there that include how to implement mistreatment kits, dementia programs, delirium programs, fall mobility implementation toolkits on the website, ways to incorporate this into workflows in the ED, and a huge packet that was developed specifically, for example, even around delirium. So lots and lots of resources on the GEDC website. Okay, I'm going to shift gears now and talk a little bit about geriatric emergency department accreditation. And so in the last 14 years or 15 years or so, we've gone from like no GERD-EDs existing to now there are well over 500 accredited, certified, recognized geriatric emergency departments. The American College of Emergency Physicians created an accreditation program that recognizes emergency departments at 3 levels, anywhere from a level 3, which is like bronze level, and is designed to be within reach of any type of emergency department or hospital. So you could be a resource limited rural hospital, you should be able to achieve a level 3 geriatric ED status, all the way up to level 1 and 2, which are designed to reflect emergency departments that have even greater commitment to senior specific or geriatric specific emergency care. For more information, you can get this on ACEP's website. I include a QR code on this slide if you want to go directly to the website. And I will tell you, this program debuted in 2008, and less than half a decade later, or a little more than half a decade later, they were already undergoing and increasing the rigor of their criteria for what qualifies to be a geriatric ED. I'll go over some of that with you in a moment. So a level 3 or bronze level geriatric ED is recognition of an emergency department that provides good geriatric ED care. You have to have at least one physician and one nurse champion that have some training around geriatric emergency care. For the physician, it's 4 hours of geriatric specific emergency care education. You have to have implemented one geriatric care process initiative in your emergency department, plus 3 baseline at minimum processes that minimize urinary catheter use in older adults, minimize NPO status, and minimize restraint use. So you have to have 4 things that you're doing in your emergency department around geriatric patient care. You also have to have access to mobility aids and access to food and drink. For a level 2 emergency department, there's quite a bit of a jump. Going to a level 2 or silver status, you continue to have nursing and physician champions, but more hours of education. You have to have specifically some type of case manager. Many places have a nurse case manager, at least 56 hours a week in your emergency department that's, facilitating care coordination for your older patients. You have to have a transdisciplinary assessment team. So at least 2 of the following: physical therapy, occupational therapy, social work, and or pharmacy available in your ED as part of your program. Hospital leadership needs to advocate, so a letter of support really saying why this is important and that resources are being provided to ensure that your programs exist. All around education for all your physicians and nurses. And you have to now have 7 geriatric specific processes in addition to the 3 baseline care processes. So a total of 10 initiatives around geriatric patient care. You have to be prepared to demonstrate that you're doing this as part of quality improvement and could be at risk for a random audit check by ACEP, ensuring that you're adhering to these guidelines and policies and procedures. And you have to track at least 3 outcome measures that are associated with your 10 initiatives. And at baseline, you also have to have the food and drink and access to supplies. So pretty big jump from level 3 to level 2. Going to level 1 or gold status is even higher. So now you have to have more education. You have to have case managers, even more assessment teams. You have to have 20 initiatives, so 17 geriatric specific care processes in addition to the 3 baseline. You have to be ready for random chart audits, and there is a more rigorous QI process of adherence that's checked on. And you have to track multiple outcomes as well. The additional thing with a level 1 is you have to demonstrate that you've created now a physical environment that really supports geriatric care. So space, chairs, lighting, noise reduction, signage, handrails, the non-slip floors, and again, access to food and drink. So sort of the center of excellence or geriatric ED care that is being administered in your emergency departments. So that concludes my portion of the talk. I'm going to now have us shift over to 2 AMA questions for those of you who will be seeking CME. And so the first question is, which of the following symptoms is not a feature of delirium? 1, poor ability to concentrate on a specific question or task. 2, inability to communicate verbally. 3, acute onset, often in relation to illness or injury. And 4, fluctuation in alertness or attention. So the correct answer is inability to communicate verbally. Answers 1, 3, and 4 are all features of delirium. And I think another way to think about this is poor ability to concentrate on a specific question or task. That's really inattention. The acute onset, often in relation to illness or injury, that's that change from baseline mental status. And then 4 is fluctuation of alertness or inattention. What you don't see here is sometimes disorganized thinking is the 4th feature that can often also be present. Second question. An 86-year-old nursing home resident is transferred to the ED after fall and now has altered mental status. You are unable to obtain any history from the patient. What is the single most important source to reference when receiving patients from an outside facility? 1, records transported with the patient. 2, history from the family. 3, report from the physician at the outside facility. And 4, baseline functional status and advanced care planning. So the answer here is 4, baseline functional status and advanced care planning. All 4 of the questions are important, but if you could only get one, which is the most important? And this one with regards to baseline functional status and advanced care planning, because these address in many ways that what matters aspect and really understanding, well, what's the priority with regards to this patient and are we able to meet their needs? And then with regards to baseline functional status, this is both physical function and also cognitive function. And so really understanding, is this a change from the baseline? If patient has always been bedbound, are we as worried about them falling because they're ambulating? They're not ambulating. So understanding things like that. So thank you so much for your attention. That concludes our talk. And if you have any questions, please feel free to reach out to myself, Eula Wong, at nyulangone.org or to Dr. Martine Sannon at mssm.edu. Thank you so much.